Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Continuing Education, SOCE. Master's Degree Programs. Master of Science, Food Nutrition, MSCDFSM, Revised. Second Year. MFN 005 Clinical Therapeutic Nutrition. Unit-12 Nutritional Management of Metabolic Diseases I, Diabetes Mellitus. 12.1 Introduction. You have already learnt about nutrition care for weight management, Unit 8, and nutritional management of cardiovascular diseases, Unit 9. In the Unit 12, we will learn about the nutritional management of diabetes mellitus, which is an important metabolic disorder of public health significance. Metabolism is a term that we must understand. It means the sum of physical and chemical changes taking place in living cells. It includes all reactions by which the body obtains energy from food and spends it. So when we say metabolic diseases, these diseases refer to those disorders in which the various reactions in the cells are affected, production of energy or utilization of energy, due to abnormal production of one or more hormones, or a deficiency of an enzyme. The metabolic diseases that we will deal with are diabetes mellitus, gout and disorders due to inborn errors of metabolism such as phenylketonuria, tyrosinemia, maple syrup urine disease, homocystinuria and galactosemia. This unit will focus on diabetes mellitus, while gout and disorders due to inborn errors of metabolism are covered in the next unit, i.e. Unit 13. Objectives. After studying this unit, you will be able to classify and categorize the various types of diabetes mellitus, discuss the etiological factors and symptoms of this disorder, elaborate on the metabolic changes in disease condition and complications linked with diabetes mellitus, describe the nutritional management of the disease, and provide diet counseling regarding prevention and control of diabetes mellitus. 12.2 Diabetes mellitus. Diabetes mellitus is a metabolic disorder characterized by decreased ability or total inability of the tissues to utilize carbohydrates, glucose. This results in shifts and disturbances in the fat and protein metabolism and in water and electrolyte balance. The disorder is due to absence of insulin, its deficiency or ineffectiveness. The hormone is produced by the beta cells of islet of Langerhans in the pancreas. In the moderate and severe cases of long duration, it is associated with permanent and irreversible functional and structural changes in the vascular system of the body, affecting organs such as the heart, brain, kidneys, eyes and even the nervous system. 12th February 2001 Prevalence of diabetes mellitus. The incidence of diabetes has been increasing in developing countries and is attributable to a great extent to the Asian paradox. Remember, we learnt about Syndrome X in the former unit on cardiovascular diseases. Evidence from epidemiological studies clearly points that Indians as an ethnic group have a very high risk of developing diabetes, particularly type 2 diabetes, about which we will learn a bit later in this unit. Increasing urbanization and affluence, changes in lifestyles, together with increased life expectancy, have resulted in an increased prevalence of diabetes. Diabetes mellitus, or Madhumeham, as it is referred in India, has been known for centuries. This is a disorder in which there is an excess sugar in the blood and the urine. Normally, insulin utilizes the sugar from the blood for energy production. This prevents the high sugar in the blood. When diabetes strikes, it could be due to two problems. 1. The pancreas cannot produce sufficient amount of insulin to remove the sugar from the blood, and second, the insulin produced is not effective and results in an inadequate utilization of the blood sugar. Hence, there is a rise in blood sugar levels. If the blood sugar rises above the level of 180 mg 100 ml in the blood, then the sugar is excreted in the urine also. Diabetes cannot be cured, but changes in lifestyle and diet and drugs can make an individual lead a normal life. Remember, in diabetes the blood and urine sugar levels are high due to inadequate production or lack of effective insulin. Diabetics can lead a normal life if lifestyle, dietary changes are made. 12th February 2002 Classification and Etiology of Diabetes. Several forms of diabetes have been identified as a result of research and survey conducted worldwide. These forms of diabetes include Type 1, Insulin-Dependent Diabetes Mellitus, IDDM. Type 2, Non-Insulin-Dependent Diabetes Mellitus, NIDM. Type 3, Malnutrition-Related Diabetes Mellitus, MRDM. Impaired Glucose Tolerance, IGT. Gestational diabetes. Let us learn briefly about each one of these types. Type 1, Insulin-Dependent Diabetes Mellitus, IDDM. Mostly children and adolescents suffer from this type of diabetes, however, it may appear in adults and elderly too. In this, there is little or no production of insulin by cells of the pancreas. Hence, the young individuals require daily insulin injections. If daily injection is not taken, there could be life-threatening metabolic complications and the symptoms could be very severe. Since various types of insulins are available, short-term and long-term, the carbohydrate content of the diet has to be adjusted accordingly. More people are underweight in this type of diabetes. Type 2, Non-Insulin Dependent Diabetes Mellitus, NIDM. Overweight and obese adults are generally afflicted by this type of diabetes. The insulin produced by the pancreas is normal or even high. The symptoms of the disease are gradual. The problem is caused by insulin resistance. Obesity is the main cause of insulin resistance. Weight reduction, diet and exercise can be helpful to decrease the insulin resistance. Anti-diabetic drugs can also be useful. Type 3, Malnutrition-Related Diabetes Mellitus, MRDM. This type of diabetes has been categorized as a separate entity. It is often seen commonly in developing countries, India being one of them. It occurs in the young, mostly between the ages of 15 to 30 years. People look thin, lean and malnourished. The reason for this type of diabetes is that the pancreas does not produce enough insulin, necrotic tissues on the pancreas, and hence these individuals require insulin. Very often hormonal disorders may occur. It has also been seen that when insulin is discontinued, the complications are lesser than type 1 diabetes. Impaired glucose tolerance, IGT. Glucose tolerance is assessed by taking the fasting blood sugar value. An oral glucose load of 75 grams glucose is administered and blood sugar value checked again after 1.5 to 2 HRS. The value of sugar obtained is checked against the normal or fasting value. If values are above normal, then we describe the condition as impaired glucose tolerance. In this type, the individuals are free from the symptoms of diabetes, but they could develop diabetes at a later stage if they are unable to control the diet and avoid obesity. Regular exercise also helps in maintaining the blood sugar levels. Gestational diabetes. When a pregnant woman develops diabetes, it is known as gestational diabetes. It occurs in only 1% of the pregnant women. Pregnant women who have a risk of diabetes because of family history or bad obstetrics history should be screened for diabetes. Pregnant mothers develop diabetes-related complications and after delivery may also continue with the diabetic conditions. Besides the types of diabetes discussed above, another form of diabetes, namely maturity onset diabetes of the young, MODY, is being identified. Maturity onset diabetes of the young, MODY, refers to any of several rare hereditary forms of diabetes mellitus due to dominantly inherited defects of insulin secretion. As of now, 6 types have been enumerated, but more are likely to be added. MODY-2 and MODY-3 are the most common forms. The severity of the different types varies considerably, but most commonly MODY acts like a very mild version of type 1 diabetes, with continued partial insulin production and normal insulin sensitivity. Age of onset for MODY is usually 25 years, or it may develop earlier. Having reviewed the diabetes types, next we shall move on to the etiology of the disorder. Etiology. The precise etiology of diabetes is not known, but multiple factors contribute to the disorder. These are reviewed here with type I diabetes. Factors contributing to the disease are both genetic and environmental. These are enumerated in Table 12.2. Table 12.2, Etiological Factors. 1. Genetic. There is a familial tendency to develop type I diabetes. Altered frequency of certain, HLA, human lymphocyte antigen, usually a protein, foreign substance that produces antibodies, on chromosome 6. Abnormal immune response, autoimmunity and islet cell antibodies are noted. 2. Age. The disease can occur at younger age. 3. Sex. In younger group males are prone, but females are afflicted in greater numbers. 4. Dietary factors. Low intake of fiber in the diet is associated with diabetes. Excess food, especially refined food, causes an energy imbalance, may lead to obesity. A risk factor for diabetes. Over and undernutrition are important etiological factors. 5. Infections. Viral infections such as measles and mumps can trigger abnormal autoimmune response that destroy the cells of pancreas which produce insulin. 6. Increased catabolism. Excess breakdown of liver sugar, glycogen, tissue, protein and fat breakdown cause metabolic changes, causing diabetes. 7. Stress. Stress is a contributing factor in precipitating this disorder. Type 2 diabetes, besides some of the above genetic and environmental factors, imbalance of hormones can cause this type of diabetes. Many of these hormones may be insulin antagonist. These hormones include growth hormone. About 1/3 of diabetics have been shown to have excess growth hormone. Adrenocortical hormone, cortisol and corticosteroids lead to an increased protein breakdown and inhibit sugar utilization by the tissues, thus increasing blood sugar levels. Adrenaline. This hormone increases the breakdown of glycogen, the storage form of glucose, in the liver. It also suppresses the insulin secretion, thus increasing the blood sugar level. Thyroid hormone. Excess thyroid hormone aggravates diabetes. Besides imbalance of hormones, diseases too could be an etiological factor. Diseases. In aging, a very important cause of diabetes could be an underlying disease. Diabetes occurs secondary to some other disorders, which may lead to insulin insensitivity or impaired secretion of insulin. These diseases are pancreatitis, inflammation of pancreas, carcinoma of pancreas, pancreatectomy, surgery of pancreatic duct. Mostly type 2 diabetes shows insulin resistance. Gestational diabetes is the temporary diabetes seen in pregnancy. This is due to increased production of hormones which are antagonistic to insulin production. Excess food, lack of exercise and aging are environmental factors for diabetes besides the generic factor. Having learnt about the causes of diabetes, next let us get to know about the factors affecting the glucose levels in blood. 12.2. 3 factors affecting normal blood sugar levels. Earlier in our discussion, we learned that insulin is the most important factor responsible for normal blood sugar levels. Now we will learn about the various factors that can increase blood sugar levels and those that can reduce it. First of all, let us know what is the normal sugar level, glucose, in the blood. The normal sugar level ranges from 80 to 110 mg 100 ml. This is the fasting level also. Figure 12.1 shows some factors that increase the sugar levels and others that decrease the sugar levels. Look at the screen. Figure 12.1, factors affecting glucose levels in blood. So we have learned that insufficient production or insulin resistance can cause diabetes, commonly known as primary diabetes. Factors that increase sugar levels like hormones, intestinal disorders, diseases in which there is heavy breakdown of proteins, stress and trauma, dietary habits, lack of exercise, metabolic disorders, can also cause disturbances in the normal sugar levels, leading to abnormal or impaired glucose tolerance, IGT. Diabetes due to factors other than insulin is known as secondary diabetes. We can conclude therefore that the etiology of diabetes is multifactorial. Most common form of diabetes of course is primary diabetes. Now, we shall see what are the symptoms of diabetes. Let us find out. 12th February 2004 Metabolic aberrations and symptoms. We all know that insulin exerts an important role in the maintenance of normal blood glucose levels through its effect on the metabolism of carbohydrate, fat and proteins. Three major effects of insulin on the metabolism include 1. Decreased utilization of glucose by the body cells with a resultant increase in the blood sugar levels to ranges between 300 to 1200 mg/dl. Thus we can say that the carbohydrate metabolism gets affected and the body cells do not get the fuel for energy purposes. 2. Markedly increased mobilization of fats from the fat storage areas causes abnormal fat metabolism, as well as deposition of lipids in vascular walls that cause atherosclerosis. Thus, the body depends more on energy derived from fat than that derived from carbohydrates. When this happens, the level of acetone, acetoacetic acid and hydroxybutyric acid in the body fluids rises, thus causing a condition known as acidosis. A second effect which is even more important is the direct increase of ketoacids. These ketoacids have a low threshold for excretion by the kidneys. As much as 100 to 200 grams of ketoacids can be excreted in the urine each day. Because these are strong acids, they combine with sodium derived from the extracellular fluid, replacing the extracellular fluid sodium with hydrogen ions, thereby making the urine more acidic. This causes rapid and deep breathing. These extreme effects occur in severe or poorly managed diabetes, leading to acidic coma and even death. 3. The third effect is on the depletion of protein in tissues of the body, causing changes in the protein metabolism. The catabolic activity of muscle protein is accelerated in diabetes, leading to increase in nitrogen that must be excreted after deamination. Also, the cellular potassium in the blood is increased, which needs to be excreted in the urine. Uncontrolled diabetes affects not only carbohydrate metabolism but also the fat and protein metabolism. Having gone through the discussion above, you may now be in a position to understand the metabolic aberrations occurring in the body due to deficiency or ineffectiveness of insulin. Next, let us review the clinical sign and symptoms linked to diabetes. Clinical symptoms. In mild cases of diabetes mellitus, no symptoms may be seen. The diagnosis could be incidental during a blood or urine investigation. In most severe cases of diabetes, the clinical symptoms are more pronounced. These have been mentioned in Table 12.3. Table 12.3, Clinical symptoms of diabetes mellitus. 1. Polyuria, excessive urinary output, especially at night. In very small children, bedwetting may be commonly seen. 2. Polydipsia, excessive thirst due to loss of water from the body. Polyuria. 3. Polyphagia, increased appetite, urge for sweet items of food due to heavy loss of sugar in urine. 4. Loss of weight in spite of eating more. Polyphagia, there is loss in weight. 5. Lassitude and untreated diabetes can cause easy tiredness, drowsiness. lack of energy and even coma at later stages. 6. Pruritus vulvae, irritation in the genitalia caused by local deposition of sugar from urine. It can also cause disturbed sleep. 7. Paresthesia, a tingling sensation felt in the hands and feet. 8. Blurring of vision, excess sugar deposits on the eye lens causing refraction. Changes resulting in the blurring of vision. 9. Delay in wound, lack of nutrients to the wound delays wound healing. Healing and minor recurrent infections occur. Boils, foot, skin and infections, urinary infections. If major infections, consult the doctor. Polyuria, polydipsia, polyphagia, loss of weight, paresthesia are earliest symptoms of diabetes. Polyuria is due to the osmotic diuretic effect of glucose in the kidney tubules. In turn, the polydipsia is due to dehydration resulting from polyuria. The failure of glucose and protein utilization by the body causes loss of weight and tendency towards polyphagia. The paresthesia apparently is also caused by loss of body protein. Diabetics should take special precautions to prevent infections of the foot and the urinary tract. Having learned about the clinical signs and symptoms, let us learn about the diagnostic criteria. 12.2. 5. Diagnosis. Timely and proper diagnosis plays a key role not only in identifying new cases but also in managing old cases with or without diabetic complications. Certain diagnostic tests help in understanding the previous history of a diabetic and also in preventing the onset of future complications. Let us review some of these. When sugar is suspected in the blood or urine, then tests need to be carried out to confirm that an individual has diabetes. We will briefly talk about these tests. These are the oral glucose tolerance test, OGTT, urinary sugar test, Benedict's test, glycosylated hemoglobin test. Let us discuss each of these. Oral glucose tolerance test, OGTT. This is most commonly used diagnostic test, particularly for identifying new and at risk individuals. This test is carried out after fasting overnight, 12 hours. Glucose 75 g in adults and 1.75 g kg body weight in children is administered orally, dissolved in glass of water before the glucose load and 2 hours after the blood samples are taken and estimated for sugar levels. The diagnostic criteria for impaired glucose tolerance test, IGT, is given in the table 12.4. In normal individuals free from diabetes and with no impaired glucose tolerance, the fasting sugar levels are between 80 to 100 mg 100 dl. The blood sugar levels increase after glucose load and come down to basal level after 2 hours. Urinary sugar, Heuristics Benedict's test. No sugar glucose is excreted in the urine in normal individuals. In diabetics, glucose is excreted by the kidneys when the blood sugar levels are more than 180 mg dl. This is known as the renal threshold. Varying amounts of glucose is found in the urine depending on the severity of diabetes and also the intake of carbohydrates. This test is not as reliable as the blood sugar test since reducing sugars such as lactose in lactating women can give a positive test which is not related to diabetes. Today, commercially diagnostic strips, heuristics, are available with the chemists. The strip is dipped in the urine and the color change on the strip indicates the sugar level in the urine. Another method of checking sugar in the urine is called the Benedict's test. In this test, 8 drops of urine and 5 milliliters of Benedict's solution are taken in a test tube, mixed and heated for 5 minutes. Change of color indicates sugar in the urine. The interpretation of Benedict's test is given the table 12.5. Self-monitoring by this method can be done several times if diabetes is severe, blood sugar levels at 180 mg or more per 100 dl. It is better to carry the test in the morning in the second urine sample. Urinary sample will more or less reflect the blood sugar level. Table 12.5. Interpretation of Benedict's test. Look at the screen. Glycosylated hemoglobin. Glycosylated hemoglobin values give important diagnostic inferences regarding the recent past of a diabetic, i.e., how well did he/she manage the hyperglycemia over the past few months. It is currently one of the best ways to check whether diabetes is under control or not. The higher the value, the poorer has been the management. It is based upon the concept that excess blood sugar level circulating in the blood gets attached to the pigment, hemoglobin, present in the red blood cell, RBC, to make a glycosylated hemoglobin called HbA1c. This deposit increases with the degree of diabetes. The combined glucose and hemoglobin in RBC can be estimated. This level is high in diabetics, 8 to 18% range, as compared to normal individuals, 4 to 7% range. The glycosylated hemoglobin reflects the trend of sugar levels in the blood during the past 2 to 3 months. Patients having high values should be identified as the target groups for rigorous counseling regarding management of hyperglycemia. It must be clear by the discussion above that these tests need not only be used for identification of new cases but also for the management of old chronic patients. Regular assessment of vital parameters such as renal, blood and liver function tests along with blood glucose and glycosylated hemoglobin can prevent or delay the onset of several complications which arise due to sustained elevated blood glucose levels. These complications may be acute or chronic in nature and need to be handled as of utmost urgency by the entire medical team. Let us brief ourselves on some of the common complications. 12th February 2006 Complications of diabetes. Diabetes, as you know, is a lifelong disease. We have said earlier also that it can be controlled but not cured. Control of diabetes by ensuring normal blood level is important for preventing the complications to develop, but sometimes they do develop as acute or chronic complications. Let us read further and see what we mean by these complications. Acute complications of diabetes. Acute complications of diabetes include hypoglycemia or low blood sugar. The most frequent cause of low blood sugar is poor timing of meals and snacks. As you know, the treatment program is based on proper balance of insulin, food consumption and exercise. Hence, by reducing the food intake, by skipping or delaying a meal or snack, the amount of sugar in the blood will be less than if one had followed the normal meal. This creates a situation in which there is more insulin than needed for the sugar in the blood. The insulin will work on whatever sugar it gets and lower the existing blood glucose levels further. The second cause could be exercising more than usual without adding an extra meal or snack in the diet. So the usual amount of insulin and increased exercise can lower the blood sugar level further. Low blood sugar can also be caused by accidentally taking too much of insulin. When this occurs, more insulin is present in the body than needed. The extra insulin works on glucose, sugar, already in the blood, resulting in abnormally low blood sugar. The symptoms of low blood sugar are called insulin reactions or hypoglycemia. These reactions appear suddenly and must be treated immediately. Symptoms appearing first are shakiness, nervousness, sweating, dizziness, weakness, irritability and hunger. Symptoms that develop further but slowly are crying, anger, drowsiness, confusion, staggered gait, inability to complete work, blurred vision and headache. If the above are not treated immediately, more serious symptoms may eventually develop. These are increased confusion, delirium, convulsions and unconsciousness. If the individual is conscious, encourage him or her to eat a fast acting carbohydrate, such as sugar, honey, sweet or a chocolate and Coca-Cola. Stop all activity and allow to rest for 10 to 15 minutes. The glucose in the food should raise the blood sugar levels quickly. If not, try the second time. If unconscious, a friend, a family member should come to the rescue. The individual may need an injection of glucagon. Glucagon is a hormone like insulin but produced by the alpha cells of islets of Langerhans and the pancreas. It has an action opposite to that of insulin as it increases blood sugar. Diabetics should avoid sudden changes in food consumption, exercise and insulin dosage. Hyperglycemia, abnormally high blood sugar, maintenance of blood glucose levels within or close to the normal range has been stressed by all medical authorities worldwide. Even with conscientious effort, there may be times when the blood sugar is high or abnormally low. Either of these two conditions left untreated can lead to serious problems. We have already learnt about low blood sugar, hypoglycemia, and now let us see what can happen during hyperglycemia. Ketoacidosis. This condition occurs when there is not enough insulin to meet the body needs, and the deficiency is allowed to continue uncorrected. With high sugar levels in the blood, the sugar in the urine is excreted at high levels. In addition, the body breaks down fat for energy and ketones are made. Increased production of ketones is known as ketosis and their elevated levels in blood is referred to as ketonemia. Their increased exertion in urine is referred to as ketonuria and the term ketoacidosis includes all the above-mentioned disorders associated with enhanced fat breakdown. Ketoacidosis is an extremely serious condition which can cause diabetic coma or even death. The onset of ketoacidosis is gradual. But when ketones are present, it is important to test for both glucose or ketones in the urine. Do you know how ketoacidosis develops? The chain of reaction begins with insufficient insulin to meet the needs of the body. Several factors then work together. These include 1. Illness, infection, injury or emotional stress could increase the body's need for insulin because of the extra energy required. Effectiveness of available insulin would also require release of additional glucose from liver, already stored as glycogen, or from fat sources. 2. Omitting insulin doses, which reduce the amount of insulin available to the body. 3. Reducing exercise, thereby upsetting the food, insulin and exercise balance. This factor and other factors given above may aggravate the tendency towards ketoacidosis. 4. Excessive amounts of carbohydrate food may also aggravate the ketoacidosis. What will happen? Without enough insulin, two things can happen. Firstly, the cells of the body will be unable to use the glucose in the blood for energy. Secondly, glucose cannot be converted to glycogen in the liver for future use. Thus blood sugar levels will rise and the sugar levels reach above 180 mg 100 ml. The extra sugar will spill into the urine, causing high levels of sugar in the urine. So to make energy available, the fat sources will be used for getting energy, as a result of which ketoacids in the blood and urine will increase. The onset of ketoacidosis is gradual, but in the young diabetics this development is faster. Diabetic coma can develop in 12 to 24 hours. Many symptoms are similar to hypoglycemia, but additional symptoms can appear. These are excessive urination, excessive thirst, increased hunger, drowsiness, unexplained weight loss, slow healing of cuts and wounds, dry itching skin, vaginal itching, abdominal pain and rapid shallow breathing with acetone smell. Can we prevent ketoacidosis? Normally, while maintaining a good sugar control, there is a very little danger of ketoacidosis. One should test for ketones under the following conditions. Blood glucose levels are about 240 mg 100 ml. Fever is present. Nausea and vomiting. Stress, and if insulin dosages is being adjusted. Severe ketoacidosis is life-threatening condition. The patient need hospitalization and care by a physician immediately. We will now proceed towards the long-term complications which are generally observed among old cases of diabetics, i.e. after the initial diagnosis. B. Chronic complications. These occur gradually when the diabetics do not monitor the blood sugar and they are careless about eating, exercise and the medications, as a result of which the blood sugar levels are high. Uncontrolled diabetes with circulating high sugar and lipids precipitate vascular disease. The chronic complications arising due to uncontrolled diabetes are highlighted here with atherosclerosis, degeneration of walls of the arteries due to fatty plaques, deposition on arterial walls, as you may recall studying in the figure 11.2 in Unit 11. Diabetics are more prone to myocardial infarction, stroke and deep artery blockages in extremities. Atherosclerosis is a common complication in the diabetics. Lipoprotein abnormalities are common in diabetics and responsible for this condition. Nephropathy, changes occur in the nephrons of the kidney due to thickening of capillary basement membrane, leading to glomerulonephrosis, disease of kidneys. These changes lead to defects in filtration, increasing the proteins in urine, proteinuria, and causing uremia, and finally renal failure, about which we will learn later in Unit 16. Retinopathy, long-duration diabetes with uncontrolled sugar may affect the small blood vessels of the eyes, microangiopathy. This can result in rapid deterioration of the eyesight, retinopathy. Neuropathy, lesions of peripheral nervous system, neuropathy, could cause tingling, burning or numbness in the sensation of the upper and lower limbs. Infections, diabetics are also prone to various bacterial, viral and fungal infections. In diabetics, cuts and wounds heal slowly. Individuals are prone to tuberculosis, infections of the skin, urinary tract and foot. The doctor must be consulted and appropriate antibiotics taken. Foot care is most important, as the common problems related to the foot are lack of circulation and neuropathy. In 5% diabetics, amputation is necessary due to negligence. Monitor and maintain sugar levels to avoid acute or chronic diabetic complications. So far we have learned about the increasing prevalence of diabetes, types of diabetes, etiology, diagnosis and briefly on the salient complications. In our next section we shall learn about the management of diabetes, wherein a dietitian plays a key role. Now that you know what is diabetes and its symptoms, complications, let us next review the management of diabetes with a particular focus on dietary management. 12.3 Management of diabetes. By now you know that diabetes cannot be cured but can be treated so that an individual leads a normal life. Patients who maintain their blood glucose levels within the normal range suffer from lesser complications as compared to those who frequently experience fluctuations in the blood glucose levels. A good synchronization between diet, lifestyle and drugs can help in preventing delaying the onset of complications. As a dietitian, our key objective involves bringing about lifelong adoptable quantitative and qualitative changes in the nutrient intake, dietary habits and food choices of the patient, as per their insulin drug dosage and lifestyle. The dietitian should work in close coordination with the doctor and other members of the patient care team. We will now discuss the details for dietary management for diabetic, which will be followed by a briefing on lifestyle modifications and drug insulin. While reading the subsequent concepts, one must keep in mind that successful management of diabetes involves a holistic approach with coordination between diet, lifestyle and hypoglycemic drugs. Insulin. Let us begin our discussions with dietary management. 12th March 2001 Management of diet. Diet plays a very important role in management of diabetes as it exerts a direct influence on the blood glucose levels. It is one of the vital components in diabetes control besides the medical, exercise and behavioral aspects of the treatment. Let us talk of the diet first. The goals of diet therapy are to maintain and prolong a healthy, productive and a happy life. This means nutritional assessment is important for setting the practical and acceptable goals for the patient. Goal that the patient can comprehend, relate to, and can be followed easily. Only after this can we plan the diet and execute it. Clinical parameters should be monitored from time to time in order to improve adherence to the program and make the necessary changes if required. Dietary changes can be made in the plans which are more acceptable and can easily be followed. This also means that diabetic diets should be individualized, based on the nutritional status of the patient. It should be practical, suited to the needs and can be followed to meet the dietary goals. What are the dietary goals? Well, here they are. These are to 1. Supply optimum nutrition to maintain good health. 2. Provide calories for maintaining ideal weight and allowing for normal growth and development, in case of children. 3. Maintain blood sugar control, glycemic control. 4. Achieve optimum blood lipid levels, and 5. Minimize acute and chronic complications of diabetes mellitus. Based on above dietary goals, Indian Council of Medical Research, 2005 gave some targets of control for diabetes which is given in Table 12.6. Table 12.6, Targets of Control for Diabetes. Look at the screen. The above objectives can be met by adhering to some of the basic principles of planning diets, which include the consideration of factors like 1. Body weight, age, sex, activity. 2. Economic, social and cultural factors. 3. Type of diabetes, mode of treatment and control of diabetes, and 4. Other factors like pregnancy, obesity, cardiovascular and renal disorders or even gastrointestinal problems and other infections. Keeping the above principles in mind, the diet plan should be such as to help in maintaining an optimum nutritional status and achieving desirable body weight. As a thumb rule, if the patient is undernourished, feed more calories, and if overnourished, reduce the calories. Calories are mainly obtained from carbohydrates, protein and fat. You already know that 1 gram of carbohydrate and proteins provide 4 cal, and 1 gram of fat supplies 9 kilocalories. Let us now understand the contribution of these macronutrients in a diabetic diet. A. Calories, proteins, fats and carbohydrates. We have learned earlier that sufficient calories should be given to maintain an ideal weight for adults and to provide for normal growth and development for children and adolescents, and also provide for the increased needs during pregnancy, lactation and illness. Calories. The energy requirements of adult patients is governed by their present body weight and the need to maintain a desirable or ideal body weight. Remember, we learnt about computations of energy requirements on the basis of ideal body weight earlier in Unit 9. Table 12.7 gives details of the energy requirements for excess, normal and underweight patients. We can calculate the energy requirements using the values. Table 12.7, Calorie requirements according to weight and activity. Look at the screen. Proteins. Proteins should be provided in adequate amounts to maintain a normal body composition and prevent depletion of lean tissue mass. Adult diabetics, without any complications, are able to maintain good health when given 1.0 grams protein kg ideal body weight per day. During childhood, adolescence, pregnancy and lactation, the requirements are higher than the RDI and patients usually benefit by increasing the protein by 10 to 15%. However, in case of renal complications, protein intake needs be restricted in accordance with the clinical parameters of renal function test. In such situations, the patient should not be given more than 0.8 grams per kg IBW per day. Fats. The total fat recommended by WHO is less than 30% of the total calories. However, in view of the widely prevalent Asian paradox in India, it is generally recommended not to provide more than 20% of the total energy from dietary fat. This is particularly important in case of obese diabetics having hypertension or cardiac disorders. Vegetable oils rich in monounsaturated fatty acids should be preferred over animal fats, which are generally rich in saturated fatty acids. Refer Table 12.8 for details regarding quantity and quality of fat. Table 12.8 Recommendations regarding quantity and quality of fat. Polyunsaturated fats, vegetable oil, 10%. Saturated fats, ghee, butter, vanaspati, margarine, 7%. Monosaturated, olive, palm, ground nut, 10 to 13%. The dietary cholesterol intake should be kept below 300 mg/day for diabetics, without any complications. However, if the patient is at risk or is suffering from hyperlipidemia or CAD, the cholesterol intake should not exceed 200 mg/day. We hope that you do remember the food sources of cholesterol we discussed in the previous unit. Well, a quick recapitulation would have taken your thoughts to sources of cholesterol such as whole milk and its products, egg yolk, red meat, organ meats, liver, kidney, brain. Carbohydrates. These to a large extent depend on the food habits. Complex carbohydrates with more fiber are recommended to simple carbohydrates like sugars. The amount should provide 55 to 65% of the day's caloric intake. The percentage and distribution of carbohydrate will vary with the insulin regimens and the treatment goals, and also individual habits. Remember, diabetics need not restrict their carbohydrate intake, but they can alter the type of carbohydrates in their diets, eat complex carbohydrates, whole cereals, pulses and vegetables, and avoid foods rich in simple carbohydrates, honey, jaggery, sugar and jams. Simple carbohydrates are not recommended for diabetics. Complex carbohydrates are beneficial. We just read about laying emphasis on complex carbohydrates. What is the benefit of complex carbohydrates over the simple ones? We will now learn about the significance of incorporating complex carbohydrates, particularly the non-starch polysaccharides. Dietary fiber, with respect to maintaining blood glucose within normal range. B. Dietary fiber. Dietary fiber is that part of food which is not digested by the intestines. High fiber meals have shown to give the best glycemic control in diabetics. It not only reduces blood sugar but lowers blood cholesterol and hence is good for cardiovascular diseases, constipation and some forms of cancer. Fiber is found in a wide range of foods such as whole cereals, pulses, fruits, green leafy vegetables, insoluble fibers. Many soluble fibers such as those present in beans, fenugreek seeds are found to be more effective in controlling blood sugar and serum lipid levels. We will talk about these later. Intake of 25 g of dietary fiber per 1000 calories day is considered optimum for a diabetic. Remember, high fiber diets are of low calorie value and also have a low glycemic index. By definition, a food product having 6 g 100 g fiber is considered as high fiber food item. So diabetics must consume more of these foods. We will tell you more about glycemic index later in this unit. Dietary fiber content of some commonly consumed Indian foods is mentioned in Table 12.9. Table 12.9, Fiber content of some common Indian foods. Foods dietary fiber, g/100 g. Cereals. Barley 15.64. Jowar 10.22. Quinoa 14.66. Rice 2.81. Wheat 11.36. Ragi 11.18. Oatmeal 3.5. Bajra 11.49. Pulses. Rajma 16.57. Lentil 16.66. Soyabean 22.55. Whole green gram, whole 17.04. Black gram, whole 20.41. Bang oil gram, whole 25.22. Nuts and oils. Almond 13.06. Gingerly seeds 16.99. Ground nut 10.38. Coconut, dry, 15.88. Roots and tubers. Sweet potato 3.99. Potato 1.69. Yam 4.08. Fruits. Apple 2.59. Dates, dry 9.10. Pomegranate 2.83. Banana 2.21. Guava 8.59. Mango 1.97. Vegetables. Drumstick 6.83. Corn baby 6.09. Fenugreek leaves 4.90. Palak 2.38. Peas, green, 6.32. French beans 4.38. Ridge gourd 1.81. Pumpkin, orange 2.56. C. Vitamins and minerals. The recommendation of vitamins and minerals is the same as for general population. However, lower levels of magnesium are associated with risk of diabetes. Magnesium depletion has been associated with insulin insensitivity, which may improve with oral supplements. Chromium supplementation has been shown to exhibit beneficial effects in diabetic patients. Mineral and other vitamins supplementation must be considered during infections and complications or situations such as extreme weight-reducing diets, strict vegetarians, pregnant, lactating and elderly, or those individuals who are on drugs and have malabsorption disorders and other ailments. Sodium restriction is suggested for hypertensive diabetics or those who are suffering from renal complications, edema. In our discussion above, we learned about the nutrient requirement. In short, we have learned that the diabetics should avoid simple carbohydrates, use fat in limited amounts, consume less saturated fats and more polyunsaturated fats, take whole cereals and pulses in right amount, use fiber-rich food in large amount, take vegetables as desired, and fruits in limited amounts. Some handy guidelines for selection of foods for diabetic patients is presented next. You may be aware that some foods need to be avoided, other used in moderate amount, and yet use some foods freely. Let us get to know which these foods are. Foods to be used freely. Vegetables, low starch. Green leafy vegetables. Spices and condiments. High fiber foods. Coffee, tea, without sugar. Foods to be used in moderate amounts. Flesh food, especially red meats. Fats. Nuts. Cereals, roots. Tubers. Pulses. Milk products. Eggs. Foods to be avoided. Sugar. Sweets. Honey. Jams. Jellies. Cakes and pastries. Pizzas. Aerated drinks and sweetened juices. Sweetened yogurt. By now you must be well versed with the dietary guidelines of diabetics. In brief, avoid sweets, use less fat, take whole cereals and pulses in right amount. Consume vegetables as desired. Take permitted fruits in moderate amounts and include as much fiber-rich foods as you can. An important aspect about dietary management of diabetics involves the concept of substituting foodstuffs having similar, not same, nutritive value or at least similar contribution to the postprandial blood glucose. The use of food exchanges is a very convenient method, which is essentially adopted by dietitians and patients for maintaining blood glucose levels within a safe range. In our subsequent discussion we shall learn about food exchanges, their characteristic features and how to use them. 12th March 2002 Food Exchange System. In a diabetic's day-to-day diet, the calorie intake and the quantity of food consumed should not have wide fluctuations. Also, the diet should not get monotonous and rigid, pressurizing the patient to take the same foods day in and day out. Variety in foods makes life more interesting. Don't you think so? For this reason we have the food exchange system, which provides almost the same amount of calories, carbohydrates, proteins and fats grouped together. By this we keep the total intake of nutrients constant, but at the same time provide variety in foods. Thus there may be difference in the weight of the food which provides the constant nutrients. For example, let us take the milk exchange as highlighted in Table 12.10. Table 12.10, Milk Exchange, provides 8 grams of protein, IFCT 2017. Look at the screen. Is this not interesting? If we know the total exchanges of milk we have to take in a day, we can have a number of choices of milk alternatives which we can substitute for milk, giving us the same nutritive content. Occasionally, we could have curds, buttermilk, cow's milk, even cheese, coa or skimmed milk, if we want to. So if we can educate the diabetics regarding all exchanges of food groups, they can play with their diet themselves. Exchanges for vegetables, fruits, cereals, pulses, meat or fats have similarly been worked out. Each exchange list will provide a number of items that can be exchanged within the group or with each food group. You will use these exchange lists while planning your diets in the practicals and therefore will be more familiar with them. Next, we shall learn about glycemic index, an important tool for planning diabetic diets. 12th March 2003 Glycemic Index, GI. Although the use of exchange lists is still popular for planning diabetic diets, it has been realized in recent years that in exchange lists, though different foods contain the same amount of nutrients, the rise in blood sugar after the meal, postprandial, varies and is not the same. This has given rise to a new concept that different carbohydrates raise the blood sugar to a variable extent. In diabetic diets, it is important to know that how much would the blood sugar rise using different foods or combination of foods. Therefore, the glycemic index concept was born. What is this glycemic index? Glycemic index is the numerical index given to a carbohydrate-rich food that is based on the average increase in blood glucose level occurring in blood after the food is eaten. The higher the number, the greater the blood sugar response. If you take a certain food and measure the rise in blood sugar in response to the food consumed in comparison with the response to an equal amount of glucose and know the glycemic index in percentage, then it would be a better method of planning diabetic diets. We do have glycemic index of individual food items such as wheat, rice, pulses and vegetables. For example, cereals like wheat, rice, vegetables, potato and carrots have a high glycemic index, 65 to 75%, fruits have 45 to 55%, lentils, peas, beans, green gram, Bengal gram, have a low glycemic index, 30 to 40%. Glucose has a glycemic index 100%. So diets with lower glycemic index are more beneficial for diabetics. These foods generally have a more fiber content. Since we do not take individual foods but 2 or more foods cooked and prepared, we would be interested in glycemic index of common mixed foods consumed by us in our main meals and also some common snacks. Work is being conducted in various institutions on this area. Someday we will have this data and would be able to switch from food exchange system to glycemic index of cooked food for planning diabetic diets. We can calculate the glycemic index of food by using this formula. GI is equal to area under 2 hours blood response curve to test food divided by area under 2 hours response for equivalent glucose into 100. You can get some idea of individual raw foods and cooked foods for their glycemic index values from the table 12.11. Table 12.11, glycemic index of some common food items. Look at the screen. These low GI foods are beneficial for diabetics. A GI of 70 or more is high, a GI of 56 to 69 is medium, and a GI of 55 or less is low. Thus, from our discussion above, it is clear that the glycemic index tells us how rapidly a particular carbohydrate turns into sugar. It certainly does not tell us how much of carbohydrate is actually present in a serving of a particular food. This information too is important if we want to assess the true impact of carbohydrate consumption. To know this, we need to understand another concept called the glycemic load. The glycemic load of a food is the glycemic index divided by 100 and multiplied by its available carbohydrate content, i.e., carbohydrate minus fiber, in grams. The glycemic load is a relatively new way to assess the impact of carbohydrate consumption that takes the glycemic index into account, but gives a full picture than does glycemic index alone. For example, if we consider watermelon has a high glycemic index, about 72. However, a serving of 120 g of watermelon has only about 6 grams of available carbohydrate per serving. So its glycemic load is pretty low, i.e., 72/106 is equal to 4.32. Perhaps suitable for diabetics. We all know that sugar, honey, jaggery, i.e., all sweeteners, which are rich in mono and disaccharides, are completely omitted from the diet of diabetics. However, craving to eat sweet meats is always high among several patients. It is for this reason that diabetics are suggested to use artificial, nutritive, non-nutritive sweeteners, which usually do not provide any significant amount of calories or other nutrients. Let us now brief ourselves on the commonly used sweeteners. 12th March 2004 Sweeteners, nutritive and non-nutritive sweeteners. Nutritive sweeteners. We know some sweeteners like glucose, honey, molasses, fruit juice, dextrose, maltose, mannitol, sorbitol, xylitol, and hydrogenated starch. Hydrolysates have shown no advantage or disadvantage over sucrose. Fructose, which occurs in fruits, vegetables, and honey, provides 4-G fructose. Through natural foods in the form of fruits and vegetables can be given in moderate amount to diabetics. Restriction of these nutritive sweeteners is because of its caloric content. Non-nutritive sweeteners, these are characterized by an intense sweet taste. They are needed in small quantities and do not make any nutritive contribution which is significant. 3 non-nutritive sweeteners available are saccharin, aspartame, and acesulfame K. In some countries, cyclamate and stevioside is available. From the data available on clinical studies, it is seen that these sweeteners have no adverse effect on diabetes control. The recommended use of aspartame has been approved by the American Diabetic Association. The recommended safe limit for aspartame is 50 mg per kilogram of body weight per day. Aspartame is commercially known as equal, NutraSweet, and sugar-free. In America, acesulfame is the newest non-nutritive sweetener available. It is available commercially as Sunet or Sweet 1. The safety limit given by FDA is 15 mg body weight per day. Let us read a little more about commercially available processed foods which have been developed particularly for diabetics. 12th March 2005 Dietetic foods. With advances in food technology, foods for special use by diabetics are now available in the global market. They are emerging in India also. These foods have reduced calories or sugar content. Diet Pepsi Cola, high-fiber flour, breakfast cereals, or even ice cream is available in the Indian market currently. A dietetic food product must contain less than 20 calories per serving and may be used as a free food, at meals or as snacks. In a day, not more than 60 calories should be obtained by dietetic foods. All diabetics should be counseled to read the food label carefully and then only select the food for consumption. What about alcohol? Can diabetic patients be allowed to take a peg or two? Let us find out. 12th March 2006 Alcohol. Intake of alcohol should be limited. It is high in calories, lacks essential nutrients and may therefore promote ketoacidosis, hypertriglyceridemia, high triglycerides, and alcohol-induced hypoglycemia, low sugar levels in the blood. Hypoglycemic drugs should never be consumed with alcohol. Patients on insulin should take not more than 2 drinks per day. 1 drink equals to 12 ounces beer, 5 ounces wine, 1.5 ounce whiskey. The composition of common alcoholic beverages is given in Table 12.12. The calorie content of drinks consumed can be accordingly calculated. Total food intake should not be reduced when the patient is consuming alcohol. When calorie intake is restricted, alcohol consumption should preferably be avoided. Women diabetics should abstain from alcohol during pregnancy and lactation. Here are some guidelines regarding alcohol consumption for insulin users. 1. Avoid drinking alcoholic beverages. 2. Take not more than 2 small drinks a day. 3. Drink only with food. 4. Do not reduce food intake. 5. Restrain yourself if pregnant or lactating. For non-insulin users, 1. Substitute for fat calories. A drink providing 100 calories should be substituted by 2 fat exchanges. 2. Avoid if your triglycerides are high. 3. Limit if calorie intake is restricted. 4. Restrain if pregnant or lactating. We read about sweeteners and dietetics foods in subsection 12th March 2004 and 12th March 2005. These foods help in improving taste and increasing variety in the diet of diabetics. In our subsequent discussion, let us learn about certain foods or food components which can help in creating a plateau effect in the postprandial blood glucose, thereby reducing the risk for developing acute complications, hypoglycemia, and at times perhaps also reduce the insulin drug dosage. Let us now read about some commonly available foods, which can be used as a supportive therapy to manage hyperglycemia. 12th March 2007 Beneficial effect of some foods, supportive therapy. Certain foods, part of food or food components, have been found to be beneficial in managing hyperglycemia. Most of these have been identified due to the presence of soluble and or insoluble fiber in them. Research has well documented evidence that soluble fiber is particularly useful for managing hyperglycemia and hyperlipidemia, particularly elevated cholesterol seen among diabetics. Some of the common and effective sources include fenugreek seeds, commonly known as methi seeds in Hindi. They are commonly used in Indian cuisine in chutney and even in pickles and several dishes. These seeds are rich in fiber, which is mucilaginous, 20 to 50% fiber content. It also contains an alkaloid substance called trigonelline known to reduce blood sugar levels. Fenugreek powder reduces blood and urine sugar levels and improves glucose tolerance. It has an action on blood lipids, lowering triglycerides or blood cholesterol. Fenugreek seeds are beneficial for use in diabetics. The same beneficial effects are not seen with fenugreek leaves. About 25 to 50 g of fenugreek seeds can be soaked in water or powdered form can be mixed in a drink of buttermilk or water. It should be taken in 15 minutes before meals 2 to 3 times a day. The seeds are bitter but benefits are great. You could use the powdered form in rice, dal and vegetable preparation. Other foods isolated fiber. It is generally recommended that diabetics should substitute whole wheat flour with soya flour, whole bang oil flour or stalks of green leafy vegetables in the ratio 3:1 while preparing dough for chapatis etc. as it helps in increasing the fiber content of meals and preventing peak rise postprandially. Wheat bran, bang oil gram husk can be given in doses around 15 g day. These show a hypoglycemic effect in diabetics. Wheat bran is best incorporated into biscuits, bran biscuits and are available in the market as high rich in the insoluble fibers. Guar gum, a soluble fiber, can also be incorporated in the form of biscuits or laddus, 20% level. Both these fibers have shown beneficial effect on blood sugar of diabetics and in type 2 diabetics have demonstrated a reduction in hypoglycemic drugs. In the beginning of section 12.3 it was highlighted that the overall management of diabetes must involve a successful coordination between the diet, exercise, physical activity, and drugs. We have discussed about the varied aspects of diet. Let us now proceed over to the role of exercise and drugs with respect to diabetes. 12.4 Exercise and drugs. In this section, we shall review the role of exercise and drug in the management of diabetes. We shall begin with exercise. 12th April 2001 Exercise. Regular controlled exercise helps to increase glucose utilization. It helps attain ideal weight by burning calories. It also builds stamina and provides a sense of well-being. A moderate exercise schedule should be part of management program of diabetes. Aerobic exercise for at least 20 to 30 minutes 4 or more times a week is recommended. Exercise after meals is preferred. There are many benefits of exercise particularly for type 2 diabetes. It lowers or eliminates the need for insulin drugs, decreases insulin resistance, helps in weight loss and maintenance of decreased weight, lowers the triglyceride and increases the HDL levels, improves circulation throughout the body, reduces stress, and reduces high blood pressure. What are the moderate intensity exercises? Walking for a half hour or jogging. Biking leisurely for a half hour. Playing tennis, swimming, gardening, golfing. Vacuuming for a half hour. Walking is the best form of exercise especially for the elderly. What precautions should be taken while exercising? Being a diabetic, the patient have to take a few precautions. These are: initiate the exercise program gently and then build it up gradually. Be particular about the intensity, timing and type of exercise. In case you get hypoglycemia, keep sugar sweet ready for use. If your blood sugar values are high and diabetes is not under control, stop exercising. It has been discussed earlier in section 12.3 that the meal pattern and the quantity of food served for each meal should be according to the dosage, timing and peak action of drugs. Insulin. We will now learn about drug and insulin commonly used for the management of diabetes. It has been discussed earlier in this unit that hypoglycemic drugs and or insulin are used for the management of hyperglycemia among NIDM and IDDM patients, respectively. You must be remembering that earlier in this section 12.3, it was mentioned that the meal pattern and the quantity of food served for each meal should be in accordance with the dosage, timing and peak action of drugs. Insulin. We will now learn about the commonly employed drugs and insulin used during diabetes mellitus. 12th April 2002 Drugs and insulin. When diet, exercise or even weight reduction do not improve the diabetic symptoms and blood sugar levels, the use of hypoglycemia drugs become necessary. Oral hypoglycemia drugs are generally recommended to NIDM patients. Several types of oral drugs are available. They work by stimulating the pancreas to release additional insulin or to help the cells of the body to utilize the insulin properly. Some Commonly used hypoglycemia drugs include sulfonylureas. Tolbutamide is the mildest and its effect remains for 8 hours. Hence 2 to 3 doses need to be taken. Another drug, chlorpropamide, needs only a single dosage as it is a stronger and a long-acting medicine. They stimulate the pancreas to release more insulin. Tolbutamide and talzamide are first generation sulfonylureas, while gleburide, glopizide, glimepiride belong to the category of second generation sulfonylureas. Biguanides, they are anti-diabetic drugs which do not affect the output of insulin. These are preferred to sulfonylureas because they do not cause weight increase. Metformin is from this group and generally prescribed to obese subjects, while sulfonylureas are given to non-obese individuals. Are there any side effects of oral hypoglycemic drugs? These are rare but may occur, such as skin rashes, itching, loss of appetite and stomach upset on weight increase. These, if present, must be reported to your doctor. Depending on the diabetic condition, the doctor can prescribe a combination of oral drugs or insulin. Let us get to know more about insulin and its types. Insulin. The discovery of insulin has dramatically changed the lives of people having type 1 diabetes. With this wonder drug, diabetics can lead a normal, enjoyable and a productive life. A dietitian should be well versed with the salient characteristics of different types of insulin in order to plan an appropriate diet and meal pattern for diabetics. Let us see what these facts are. 1. Insulin is measured in units. A unit of insulin lowers the blood glucose by a certain amount. The doctor will decide the number of units of insulin a diabetic will need per day. 2. Insulin is generally produced in 2 different strengths, U100 and U40. This means that if the diabetic takes U100, there are 100 units of insulin in each cubic centimeter. Similarly, U40 has 40 units of insulin per cubic centimeter. 3 types of insulin is available. The type varies in how quickly it starts working, lowering blood glucose, time of peak activity, when they work the hardest, and how long it works. The 3 types are short-acting, intermediate-acting and long-acting. Short-acting, this type of insulin begins working quickly, works hardest 2-3 hours after injection but is completely gone after 4 to 6 hours. So if a diabetic takes this type of insulin, they need a shot every 4 to 6 hours. This is also known as regular insulin. Sometimes, a small amount of zinc is added to the regular insulin because it prolongs its action. This is known as the semi-silent. Intermediate acting, this type works more slowly than short acting. It works hardest 8 to 12 hours after injection and still keeps on working to some extent 24 hours later. One form of this type of insulin is known as neutral protamine hagidone, NPH. Hagidone is the name of the developer and protamine is a simple protein added to it. Intermediate acting insulin is called lenti. Long-acting insulin does not work until 4 to 8 hours after injecting. Its peak activity occurs 18 to 24 hours after injection and it continues to work to some extent after 36 hours. This is used less commonly because it is easier to work with 4 hours or 24 hours rather than 36 hours. Sometimes, the doctor uses a combination of short and intermediate insulin. The carbohydrate distribution varies with the type of insulin prescribed. Keeping track of the amount of CHO in each meal is recent trend in calculating the diabetic diet and is known as carbohydrate counting. Table 12.13 shows the distribution of CHO according to type of insulin. Table 12.13, meal distribution of carbohydrates. Look at the screen. A diabetic patient need not always be hospitalized and can refer to a dietitian on a day-to-day basis. The food intake and activity level are ever-changing variables that affect blood glucose levels. festivals, religious occasion, professional and social responsibilities along with common illness such as constipation, fever, cold etc. can affect the insulin and food requirements markedly. It has, therefore, been strongly advocated that diabetics must be rigorously counseled so that they can manage their blood glucose levels themselves. Patient education through counseling sessions and mass media can help reduce the morbidities associated with diabetes. The subsequent discussion will highlight some of the points which should be kept in mind by the dietitian while planning or implementing a counseling session. 12.5 Education. Education is very important for diabetics because it is a lifelong disorder. In order to enable the patient to lead a healthy and a good quality life free from complications, the diabetics must be educated sufficiently in the areas given below. The nature of disease, its acute and chronic complications, consequences of negligence, self-monitoring at regular interval for sugar, urine and blood, and serum lipids or any weight alterations and importance of weight maintenance. Adequate information on the diet, foods restricted, foods given in the moderation and free foods, concept of food exchanges, glycemic index and planning meals. Knowledge about insulin and drugs in relation to carbohydrates. Importance of management by diet, drugs and exercise. Sick day guidelines, refer to box 12.1. Clarification of common food fads and misbeliefs, refer to box 12.2. Suitable information needs to be distributed to diabetics. This could be self-care materials, food guides or even simple innovative recipes. Audio tapes and videotapes in local languages may be developed so as to facilitate widespread dissemination of knowledge throughout the country. Box 12.1 Sick Day Guidelines. A sickness, even minor, can increase the body's need for insulin. Extra insulin may be required because of the extra energy required by the body to overcome the illness. This can result in energy needs being fulfilled from other sources of energy in the body like fats causing acidosis. On any sick day, one must consider the need and follow the sick day guidelines given below. 1. Never omit the insulin dose, even if the person is unable to eat. 2. Test the blood glucose level before each mealtime and at bedtime. 3. If blood glucose levels are 240 mg 100 ml or higher, one should also test for urine ketones. Do this when ill from any cause. 4. Take liquids every hour. 5. If the patient is too ill to follow the meal plan, advised to eat and drink whatever they can tolerate. Use fluids, water, fruit juice, tea etc. If they are unable to take fluids because of vomiting, call the doctor. Soft foods like baked custard, cooked soft cereal, creamed soups, milkshake, jelly, toast and even an ice cream can be consumed. 6. Rest or keep warm, do not exercise. Ask someone to care for the patient. If too unwell, call the doctor. Box 12.2 Food fads and misbeliefs. Some common food fads and fallacies linked with feeding diabetic patients are highlighted herewith. 1. You cannot eat rice if you are a diabetic. Both wheat and rice have a similar glycemic index, which means that they raise the blood sugar level to the same extent. As long as you restrict the quantity, see food exchange, it does not matter what you eat. 2. You can fast if you are a diabetic. Total fasting is not good, especially for those who are on insulin or hypoglycemic drugs. It causes acute complications of hypoglycemia which can be life-threatening. 3. Carbohydrates should be restricted in diabetics. It is now known that carbohydrates need not be restricted and it could provide 60 to 65% of the day's calories. Complex carbohydrates, high fiber content, found in cereals, pulses or green vegetables are known to improve the insulin action. But simple carbohydrates present in sugar, sweets, honey and jams can increase Blood sugar levels. Type of carbohydrate consumed is more important. Initial and time-to-time counseling regarding prevention and control or management of diabetes must be obtained by individuals suffering from diabetes. In case of doubt, seek the help of a dietitian. What are the preventive measures which a diabetic patient needs to practice to ensure a healthy life? These measures are discussed finally. 12.6 Prevention. We now know that diabetes is the outcome of many genetic and environmental factors. The former is not in our control, but the latter can be modified. The most important rule in the prevention strategy is to maintain ideal weight. We have already learned in Unit 9 about this concept. We can use the information given in the unit to calculate ideal weight for a diabetic patient depending on the height, gender and activity pattern. Can you not? Yes, you can. To successfully control the weight, encourage a diabetic patient to develop lifelong, healthy eating and lifestyle habits. So you can prevent diabetes by encouraging the diabetic patient to 1. Maintaining ideal body weight. 2. Avoid high sugar, salt and fat foods. 3. Take small bites and chew foods thoroughly. Eat and drink slowly. 4. Eat protein-rich food at each meal. 5. Eat wisely at social gatherings and restaurants. 6. Do physical activity. Walk daily. 7. Avoid aerated and excessive alcoholic drinks. 8. Minimize use of tobacco and other harmful drugs. 9. Use artificial sweeteners if you have a sweet tooth. 10. Read and educate yourself on various aspects of diabetes. 11. Avoid stress, enjoy good music, meditate and have positive attitude towards life. In other words, make lifestyle and behavioral changes for better health. 12.6 Summary. Diabetes, as we all know, is a disease with ever-increasing prevalence in our country. It can be described as a disease characterized by disordered metabolism and inappropriate hyperglycemia due to a deficiency either of insulin secretion or to a combination of insulin resistance and inadequate insulin secretion. In this unit we have learnt about the various types of diabetes and impaired glucose tolerance in different age groups. A brief note on the symptoms and complications of diabetes, as well as the common diagnostic tests to identify and monitor diabetes are also given. The unit further elaborated on the overall management of diabetes with emphasis on diet-related aspects. We learned that the management of diabetes involves a coordination between the diet, drugs and activity pattern of the patient. The nutrient requirements are elaborated and the use of alternative food components supportive therapy is also discussed. This unit also dealt with the significance and advantages of regular exercise for maintaining blood glucose within normal range. The use of different types of drugs, insulin, their characteristic features and duration of action were also discussed. Thereafter, a dietitian is very often involved with counseling sessions which are aimed to help the patient in becoming self-reliant regarding the day-to-day management of variations in blood glucose. Some useful tips regarding an effective education program were also elucidated. Thank you for watching. We will see you in the next video.